Welcome to week 18 of our lecture series. Today, we're going to be talking about mood disorders. These primary, more psychiatric leaning talks are going to be a little more straightforward, I hope. Um, we'll start with our learning objectives, which you can review in your own time. And as always, we'll start with some history. The earliest descriptions of deficits in mood in any kind, but especially as a disorder, was of course first appeared with Hippocrates, who explained that something called melancholia was a result of an excess of black bile. And so this linked depression to a more of a proto-biological model rather than, previous views of it as a moral or spiritual failure. And then, of course, later Aristotle got involved and he linked these emotions to bodily sensations. And then uh, you know, who knows, like 1500 years later, like in the late 1800s or so, Emil Kraepelin described mood disorders as manic depressive illnesses. And this separated them from psychotic disorders, which at that time was known as dementia precox. And then Kraepelin also, proposed that mood disorders resulted from certain metabolic disturbances in the brain, and that all mental activity is rooted in the brain. And then by the time of Freud, he sort of reframed mood as reflective of affect regulation itself. And specifically, he wrote about melancholia as anger towards as anger being turned towards a lost object. Um, and that anger was then turned inward against the self. It's almost like a pre-object relations view of if anger is towards a lost object, but then turn inwards against the self. And that leads to mood dysregulation, which was eventually known as depression. And so this kind of created the idea that the ego's role was in regulating affect itself. And so the first anatomical model of emotion was described by James Papez in 1937, which eventually led to the famous Papez circuit to be known. And then Paul MacLean later expanded this into the limbic system, which was eventually further elaborated on. And then by the 1960s, researchers like Aaron Beck and Martin Seligman helped reframe depression within more of a cognitive and behavioral model with the advent of CBT and findings of learned helplessness experiments. Just an interesting aside too. Aaron Beck, even though he's a psychiatrist, he actually initially started his training as a neurologist. He was a neurology resident in Pennsylvania and at Penn, and I guess like there was a need for psychiatry for psychiatrists, and I think he did like a 6 month sort of like rotation there, and then just kind of stayed, liked it, and stayed there, and he eventually became a psychiatrist. But yeah, he's it's a little known fact that he's sort of a neuropsychiatrist, and he was the founder of CBT. Helen Mayberg is a huge name, and we're actually going to talk about her in her own slide here, because to really understand what Dr. Mayberg did, we have to understand, how mood disorders started to be known in a very different way with the advent of functional neuroimaging, computing, like these kind of computational models and effective neuroscience as well. So some discoveries that led up to Mayberg here is that in 1995, George 1995 discovered that the dorsal or found that the dorsolateral prefrontal cortex is hypoactive during cognitive tasks. Gervais in 97 found out that the subgenual cingulate is hyperactive in treatment-resistant depression. And then Siegel in 2002 found that the amygdala is hyperreactive to negative stimuli in depression. And Schelling in 2009 found that there's impaired self-regulation of the default mode network, and that is likely underlies ruminative thinking and depression. And so all these discoveries were all eventually synthesized by Helen Mayberg into what she called her limbic cortical dysregulation model of depression, which changed the frame of this disorder from a chemical imbalance into a malfunctioning brain network disorder. And as we're going to discuss in this lecture, Mayberg basically found out it was became so confident about this that she and basically discovered that we could do neurosurgery to treat depression. Um, and cause she's the reason that we have DBS for depression. But interestingly enough, I actually spoke with her over a dinner before, and she describes her type of depression as more of a cingulopathy. And so we're not really sure if the people are very obviously very treatment resistant depressed. The people that eventually get brain surgery to do this, but um, we're not, I guess, 100% confident that this is the same, run-of-the-mill depression that we see outpatient, but definitely very similar. To see some cultural perspectives here, it's interesting to note that in more collectivist cultures, such as in the East and South Asian cultures, depression may express itself more somatically and more commonly have associated headaches, fatigue, dizziness, or even be framed in more moral and familial terms, while Western cultures tend to identify inner emotional states more explicitly verbally. Such as using the word sad, hopeless, or worthless, making depressive feelings more verbally accessible. And kind of alluding to, this thought of like, is CBT actually as helpful, for collectivist cultures as it is for individualistic cultures? Or is it more helpful for people who tend to frame, who get benefit from framing their emotions verbally? And there is research being done with that. Actually, my wife. And so some indigenous cultures may see sadness and withdrawal following, major life transitions as being just normal processes of spiritual recalibration. And of course, one's religion can provide context for their experience of mood, and just some examples here. Christianity may frame depression as spiritual dryness or loss of grace or a crisis of faith, while Islam may see suffering as a test from God, with an emphasis on community and prayer as a grounding practice. Buddhism may see emotional suffering as stemming from attachment and a reminder to practice mindfulness and more compassion. While some indigenous communities may link bad feelings as an imbalance with nature or or connections with their ancestors. And of course, it's important to note that patients will often, instinctively use these frameworks either explicitly or implicitly to better understand and regulate their own feelings. Some of the important epidemiology and public health aspects here is that depression is consistently listed in the top three causes of global disability, according to the World Health Organization, and the number one cause of disability in working age adults. As we see here, it affects 1 in 5 people over their lifetime. While bipolar is way more rare, like only affecting 1 to 2%, but still a very significant amount. And w Women are similar to anxiety. They're about twice as likely to be affected as men. Although bipolar is about the same between men and women. I forgot to mention it here. But bipolar 2 might be slightly more common in women. But as we'll talk about, it's a little interesting that bipolar 2 people tend to spend more of their time in depression. And so I'm not sure if that, are these people just having depression and, and that just happens to be a little more common in women. And so I don't know if that's a misdiagnosis or not, or if there's actually, some a circuit that somehow is more vulnerable, based on sex. I'm not really sure. But either way, these are conservative estimates. I know many cases are likely underdiagnosed completely due to poor access to care, stigma, and differences in cultural expression of depression. And depression can also commonly be misdiagnosed as just stress or burnout, or just present somatically. And although bipolar disorder is way less common, it's still among the top 10 causes of disability between ages of 15 and 44, and its peak onset is happens during people's most productive years, and so it has just enormous occupational and economic consequences too. And then cognitive dysfunction too from underlying mood disorders definitely impact people's disability, with and we'll talk more about that, but definitely has impact on processing speed, executive function, and emotional regulation. And then for neurologists, it's super important to recognize mood disorders as they're super common in their patient population. And this is similar to anxiety as well. With some examples here, like for post-stroke depression, it's important to recognize this because there's poor functional recovery if this is untreated. For Parkinson's, depression, this might commonly precede motor symptoms, with overlapping apathy and anhedonia from reward circuitry degeneration, which we'll talk about in its own lecture. Depression is also extremely prevalent in MS and thought to be related to inflammation and psychosocial burden, which we'll talk about in its own lecture. And people with TBIs are more commonly depressed, with orbitofrontal and dorsolateral prefrontal cortex injury being more strongly predictive of affect dysregulation. Um, and epilepsy, especially temporal lobe epilepsy, is commonly presents with mood disorders, and are often difficult to separate from medication-related depressant effects. There's actually a modified PHQ-9 for people with epilepsy because of the meds kind of causing similar symptoms, and it's called the NDDIE, E for epilepsy. And all of this is going to be their own lecture in neuro. So for now, let's cover the DSM-5 criteria. For the following like 3 or 4 slides or so, we're going to review this criteria. No need to memorize this, but if you want to, pause and review this in your own time, you can. We're just going to talk about broad strokes here. The DSM-5 organizes mood disorders into depressive disorders, bipolar and related disorders, and mood disorders due to either a medical or substance cause. And the classifications here are categorical and syndromic, based on just clinically observed symptoms. And so this is really more for charting and billing purposes. Going forward, we'll focus more on the presentations of these disorders, aligning, increasingly more well with brain network dysfunctions as usual. Um, so major depressive disorder is commonly diagnosed at bedside using the PHQ-9, which basically covers all of these symptoms here. But there's 9 total symptoms, and you just have to have at least 5 of these symptoms for at least 2 weeks. And you must have some kind of depressed mood to make this to meet DSM-5 criteria for depression. And so I guess like in med school, there's a lot of acronyms that we use to try to remember these symptoms. The most common one that I know is SIG-E-CAPS, which is listed here in order. So, SIGI cap, so sleep, interest, guilt, energy, concentration, appetite, psychomotor, slowing, or agitation, or in suicidality. So ask your patients always about sleep, number one. Love to ask that. And then if they have any loss in interest or anhedonia, if they're starting to have thoughts of like worthlessness, if they feel fatigued, which obviously is also very common when they're not sleeping. Um, are they having difficulty concentrating, which neuropsychologically, makes a lot of sense with depression? Are they having weight loss or weight gain? If they sometimes they don't recognize if they have decreased appetite, so I always ask about weight. Psychomotor slowing or is a neurovegetative sign of depression. It's really common, and of course, always ask for suicidality. And it's important to distinguish these symptoms as occurring outside of a bipolar depression or adjustment disorder, grief, or being secondary to a substance or a medical condition. Um, for more of the bipolar diathesis, this is defined by intermittent mania in bipolar 1 or hypomania in bipolar 2. And mania itself is defined by at least three of the following symptoms, which I remember by another acronym called DIG FAST, like DIG FAST. And so that would be distractibility, impulsivity, grandiosity, flight of ideas, activity, increase, sleep deficits, and talkativeness. And so the talkativeness is, of course, pressured speech. It's important to note that these episodes are discrete and continuous over at least a week for mania, and at least 4 days for hypomania. And so some major differences between bipolar 1 and bipolar 2 is that, of course, bipolar 1 mania just about always leads to a psychiatric hospitalization for safety because these patients are way more impulsive, disinhibited, agitated, and commonly also psychotic during their manic episodes. Well, bipolar 2, the hypomania is less likely to be this dramatic. But the important thing is that both of these things happen within a discrete period of time, and they're characterized. One of the my Because we always ask about sleep first, I always specifically ask patients if this discrete period of time, lasting at least 4 days or up to even, 2 to 3 weeks even, are characterized by a decreased need for sleep. Like basically you're sleeping like 4 hours max, if not less. And you still feel full of energy, you're doing things more impulsively, you're spending a lot of money, you're having a lot of new ideas, you're starting new business ventures, you're doing all these things that you typically wouldn't. And then, afterwards, when you go back to sort of not feeling this way, you just feel typically like bad, or do you feel like depressed? People, very rarely would feel normal after this. Um, and then even more rare is a colloquially named bipolar 3, which is a cyclothymic disorder. And this is defined as having at least one hypomanic episode and at least one major depressive episode without any prior mania. And their hypomania tends to be even less dramatic, not last as long, and be more frequent. And then there's if somebody has somebody with bipolar 1 has more than four manic episodes in a year, then they would add a we would add a rapid cycling specifier to their bipolar diagnosis. And one thing to keep in mind on the differential here is that borderline personality disorder is very commonly confused with bipolar on presentation. And the key difference is really what we already talked about with focusing on more of the biological aspects of like a discrete episode of decreased need for sleep and sustained increased energy and personality change rather than, this kind of, rather than just like mood swings or, mood lability. And so both depression and anxiety can occur due to an underlying substance or medication, or commonly in neurology, it can happen due to another underlying medical condition. And so this is very difficult to tease apart sometimes, especially with substances who might just need to be metabolized, but otherwise they may still be treated similarly. The most important differentiating factor is that the primary management will either, be either to remove or metabolize the offending agent, whether it's a substance or medication, or focus on treating the underlying medical condition. Um, and that's that. So let's talk about some of the functional neuroanatomy here. And so this model. this limbic cortical dysregulation model, which was proposed by Helen Mayberg sometime like by 2005 or so. And it links clinical symptoms, symptom clusters of depression, such as rumination, anhedonia, guilt, and the psychomotor changes that we spoke about to functional circuits in the brain. And this model has been one of the most influential frameworks in modern biological psychiatry, as it integrates data from functional neuroimaging, neuromodulation, lesion studies, computational models of emotional regulation, and affective neuroscience into one neat package. And this model, also sees depression as a combination of bottom-up affect circuits and insufficient top-down regulation, while mania is more due or thought to be due to excessive limbic striatal motivation with unregulated behavioral inhibition. The anterior cingulate cortex and specifically its subgenual part is extremely important in this model. It represents the central hub in depressive circuitry, and it's hyper reactive on PET studies of depression, and has increased functional connectivity to limbic structures. It's normalized by SSRIs, ECT, DBS, ketamine, and therapeutic remission, and it's thought to directly coordinate emotional tone, including autonomic arousal, somatic symptoms, and stress response. And so I personally like to think about the anterior cingulate cortex as sort of maintaining the emotional tone of the brain. And as we know, it's basically the main focal point between the three most important large scale brain networks, which are the salience network, which is the most important one, and its role as the switch between the default mode network and the central executive network, which are usually anti-correlated. And so if the salience network is pointing more towards the off state, which is the default mode network, which is what we see in functional imaging studies, that depression is usually characterized by a hyperactive default mode network, then it's easy for us to think that the central executive network is going to be hypoactive. And so that means that we can kind of predict a couple things here. One thing is that we can predict that the dorsolateral prefrontal cortex, which is part of the central executive network, is going to be hypoactive as well, which is what we see in studies. And we can see that the ventromedial prefrontal cortex, which is part of the default mode network, is going to be hyperactive, which is what we do see in these studies. And so, it will also, we can also infer that if the executive network is down, well, and the dorsolateral PFC is down, then our working memory, our attention, sustained attention, cognitive control, and our ability to control our emotions are all going to be down, which is also what we see in depression. And that's why we can actually target the DLPFC in TMS. And actually, if we use our TMS, the left dorsolateral prefrontal cortex is actually one of the main targets. And it's thought to stimulate and help restore this top-down inhibition over these limbic centers. While going towards more the default mode network, now we're thinking, self-referential, this ruminative quality of depression, and self-criticisms. And so, this ruminative state, if we want to get out of it, we commonly in psychiatry encourage behavioral activation, and we try to tackle these head on with CBT and with like cognitive distortions and whatnot. And what we're really doing is we're trying to get patients away from their default mode network state and try to encourage their executive network because the more that we encourage the executive network to go up, it will bring down the hyperactive default mode network. And so these dynamics are basically, the definition of depression and at least how we understand it in the modern day. There's also some subcortical structures that we'll talk about as well. that I didn't write here but are important to talk about. So one of these is of course the amygdala that's always involved. It's a hyperreactive in depression, as we talked about, and it's skewed towards negative emotional stimuli in depression. The hippocampus has reduced volume in chronic depression. And it's highly sensitive to cortisol toxicity, and might allude to why, people who have depression are you can also very commonly have anxiety. People who have anxiety very commonly have depression. And the ventral striatum, which we talked about in our addiction lecture, which is the nucleus accumbens, is also hypoactive, and that might allude to some of the anhedonia and loss of pleasure in depression. And so, integrating all of this, we see that depression is seen when the modes of the default mode network are hyperactive, and the nodes of the central executive network are hypoactive. And this leads to symptoms of the amotivation that we expect in attention, ruminative thinking, and psychomotor slowing, among others. Um, so just some, just because this has been the mainstay of depression since like the beginning of psychiatry, but there's a lot of neurochemical changes that we see in depression, and some cellular mechanisms that have been proposed. The traditional monoamine hypothesis from like the 1950s, that's super outdated, basically stated that depression is the result of a deficiency in serotonin, norepinephrine, and or maybe dopamine. Um, and by like the 1990s or so, there was a bigger focus on neuroplasticity, with the thought that chronic stress led to decreased BDNF and decreased neurogenesis of the hippocampus, and that might have been to blame for mood. And this has all been expanded in the current day after finding out that ketamine is a super rapid antidepressant. So that makes you think like, well, how does that work? So it's thought to be due to dysregulated glutamate signaling that might lead to excitotoxicity and result in the dendritic atrophy, and maybe by inhibiting NMDA receptors on inhibitory interneurons. This can lead to bursts of glutamate activity that activate AMPA, and this leads to increasing BDNF and trying to fight that all that dendritic atrophy back. And that can actually ketamine and other psychedelics can lead to synaptogenesis, which will possibly explain ketamine's rapid antidepressant effects. And inversely, GABA may also be related, going the opposite way of glutamate here, as reduced GABAergic tone is also found in depression and anxiety disorders. And there's a new antidepressant called brexanolone, which is an analog of pregnenolone, that's been shown to stabilize mood through targeting these GABA A receptors. And there's plenty of evidence to show that a significant amount of patients with mood disorders also have increased inflammatory markers. And so this is a thought of like, could that be, a cause of depression? That's definitely a thought that we have for patients with MS that we'll talk about in our own MS lecture. And so another thought of this, inflammatory state is that does it lead the brain to sort of take a sick role when it's in a high inflammatory state? And depression looks very similar phenotypically to people who are just, like whenever you're sick, you tend to be in bed and not be motivated to do stuff. So there's many, many theories of depression. And a thought that I have is that like, how can we make sense of all of these? I think that this is another example of like, of the blind men kind of touching different parts of the elephant and not recognizing that it's all the same elephant. Um, but these all these theories have therapeutic values. And so, likely there isn't one single explanatory theory, but depression is likely the manifestation of all of these, and how they converge on similar circuits. So, talking about some clinical relevance here. Starting with the diagnostic workup, of course, we always start with a history. We ask, when did, assuming that they already said that they feel bad, basically we ask, when did this start? Was it gradual? Was it sudden? How long has it been? What's the course been like? Has there been any triggers? Is it just depression, or do you and when it comes to depression, we should ask, our SIGI CAPS screening questions or psychiatric review systems. But we should also ask, is it possible that you've had a manic episode or hypomanic episode at some point in your life? So you should always screen for bipolarity for any patient that you suspect a mood disorder. So those are just those diggy fast questions. About 60% of bipolar patients tend to present with depression first. And so this has treatment implications that we'll talk about. There's different scales that we can also use too, that can help with this questioning, like the HAM-D for depression. There's the PHQ-9 for depression. And there are standardized interviews that are really commonly used for clinical trials for depression, like the MATTERS or the PSI-A. There's some mania scales that I haven't personally used before, like the YMRS or the Young Mania Rating Scale. There's also the QIDS, which is the Quick Inventory of Depressive Symptomatology, which is on MD Calc, and maybe more useful for depressive phases of bipolar disorder. It's also crucial to rule out like medical and neurologic causes. You definitely don't want to miss simple stuff like iron deficiency anemia, thyroid issues, adrenal issues, and certain inflammatory conditions and vitamin deficiencies. So always order like TSH, CBC, CNP, B12, folate, A1C, lipids, pregnancy tests, and urine drug screen. You can also consider, if the specific case warrants it, ESR, CRP, ANA, HIV, maybe RPR and cortisol, lithium level, Depakote level if they're on it. Also an EKG just for a baseline QTC, as a lot of these meds might prolong that. And as we discussed, it's also really important to consider any underlying neurologic conditions that might present with mood changes. So like strokes, Parkinson's disease, MS, epilepsy, TBI, brain tumors, especially if it's like frontal or limbic. Um, Normal pressure, hydrocephalus, Huntington's, definitely, and autoimmune encephalitis as well. Just be mindful of medications and substances that might be exacerbating it or kind of conflating the clinical picture, like steroids, opioids, alcohol, cannabis, benzos, dopaminergic agents, stimulants, antidepressants too, modafinil or anti-seizure meds. One thing that's kind of interesting is that antidepressants can actually sometimes exacerbate apathy. So it's important to also differentiate between depression and apathy, especially in like people with like Parkinson's, for example, or TBI as well. And for select cases, we can consider neuroimaging, but these are very specific cases, like if it's like new acute onset depression or mania in like an older adult, if there's any focal neurologic deficits, cognitive impairment that really can't be explained by the mood disorder itself. There's some atypical psychotic features. We can also think of depression with psychotic features. If there's catatonia, treatment-resistant depression, or any other suspected neurologic cause. And I guess if cognitive deficits are present, it's hard to separate from mood disorder. You can also consider neuropsychological testing. Because this phenomenon of like pseudo dementia is super common with depression. And like we said, if the salience network is pointing towards the default mode network and the central executive network is down, that means the dorsolateral prefrontal cortex is hypoactive, meaning that the patient's, working memory, attention is going to be not functioning pretty well. And so that can look like almost like dementia for the right person. So it's important to know just like their baseline, intellectual ability, just so we know if they had any previous developmental issues to begin with, if they have any comorbid neurological conditions that might be affecting their frontal lobe function, before we consider like an actual like neurocognitive disorder. And so, to try to differentiate between these two, we could have a battery of neuropsychological testing if it's warranted, as there is a lot of shared features here like slow processing, impaired retrieval, and distractibility between both pseudodementia and dementia. And mood disorders are more likely to have a faster onset of memory complaints. And it typically tends to bother patients more than dementia patients. And and in contrast with this, like, in dementia patients, it's usually the families who tend to notice these cognitive issues more. And people with mood disorders tend to have a more inconsistent performance on memory tasks. And of course, will improve with treatment. So it's really important to know that, they have a reversible cause of cognitive deficits rather than the latter. And then mood disorders will impair attention, processing speed, memory, executive function, and social cognition. And these deficits will all predict functional disability, employment outcomes, relapse risk, and treatment response. So these are all very important to screen for and treat because, it can have some significant long-lasting effects in people's lives. Um, the meds there's a whole lot of ways to treat depression. And so you can or sorry, pause this video and review this at your own leisure. But we're just kind of going to try to keep it simple. The first six rules here are all for classic depression. And so these are, first line starting from the top will be SSRIs. Unless there's another indication to use something else, SSRIs are typically your first line. Some indications to use something else would be like if there's comorbid fibromyalgia or fatigue, maybe we'll consider SNRIs. If we want some like off-label benefit for like ADHD or like smoking cessation or something like that, then we can consider Wellbutrin or bupropion. And then, of course, like these other ones like tricyclics and MAOIs aren't really commonly used for depression anymore because their side effects kind of limit them from getting, up to a good dose. But so in neurology, very commonly use TCAs like amitriptyline for like at night or nortriptyline for migraine prevention. And MAOIs are commonly used in Parkinson's disease. So it's important to screen patients for bipolar before starting any serotonergic agents, which are basically any of the meds in the first six here, with the exception of maybe Wellbutrin. And because it's thought that serotonin can actually precipitate mania in patients in the bipolar sort of spectrum. And then in the next four roles, starting with lithium. So lithium, Depakote, lamotrigine, and atypical antipsychotics. These can all be used as mood stabilizers for bipolar disorders. Lithium is the gold standard. And has anti-suicidal effects, and it can be used in acute mania and for long-term management. It's my favorite one to use. You just have to make sure to get basic labs, make sure that their kidneys are okay. Lithium has a narrow therapeutic index, so we like to get levels. So when we start patients on this, this should hopefully actually be started by a psychiatrist. Um, and yeah, very important to continue monitoring both kidney and thyroid function on this. It is associated with some weight gain, but it tends to happen more earlier on in treatment rather than like long term. Same thing with Depakote 2 can also cause some weight gain. And so Depakote is good because it works really fast, especially for acute mania. You just have to make sure that, be mindful that if it's a person that's a woman of childbearing age, who isn't on contraceptives, Depakote is associated with neurotube uh, deficits in the child. So definitely, don't start it for those patients. Lamictal would be a safer option, but of course we can't use that acutely. It's a slow titration schedule to avoid, the potential risk of Stephen Johnson's. And it's actually more commonly used and indicated for bipolar depression. Atypical antipsychotics are increasingly being used for bipolar disorder, and it can also be used as an augmenting agent for depression that's been refractory to SSRIs in first-line treatments alone. The bottom four rules here are more miscellaneous and kind of experimental. Ketamine has been the first ever rapid-acting antidepressant, and it also has anti-suicidal effects. The other two meds that have anti-suicidal effects are lithium and clozapine. The other ones are even more experimental. So we have these new GABA-A allosteric modulators like brexanolone and zuranolone. These aren't used in clinical practice just yet, but it's definitely been shown to help, especially with postpartum depression. And then classic psychedelics, such as psilocybin, are currently in phase 3 clinical trials for depression, and these are paired with psychotherapy, which we'll talk about in their own lecture. And then, some neurological medications like Sinemet may also affect mood, and it's actually being investigated for augmentation reasons for depression, and also when depression is suspected to be from an inflammatory cause. So psychotherapy. So psychotherapy has been definitely been shown to, produce some measurable changes in large scale brain networks, and should theoretically definitely be first line. I guess SSRIs tend to be first line just because they're tend to be more accessible, but psychotherapy always works better when paired together with meds, and meds work better when paired together with psychotherapy. So to go through some of the options, and especially for the sake of this lecture, it's helpful to pair to figure out how they work mechanistically when looking at the brain. And so CBT is thought to work by strengthening that top-down cognitive control through the dorsolateral prefrontal cortex. As we've alluded before, this increases the work of the central executive network, and hence dampens down that hyperactive default mode network, and works on these cognitive distortions to try to reduce rumination and negative self-talk. From the other end, psychodynamic therapy is actually thought to target more the ventromedial prefrontal cortex. This is definitely a way slower therapy, and it helps correct the structure of the default mode network to enhance its reflective functioning through resolving, possible unconscious conflicts and symbolic processing to try to improve insight and affect regulation. Mindfulness-based therapies are thought to work by focusing attention more so in the present, and the present moment can hopefully reduce, any hyperconnectivity and rumination in the default mode network, along with enhancing parasympathetic vagal tone. And you can read more about psychotherapy from the notes in this lecture. And then neuromodulation is super novel and an interesting way to actually test these theories. We'll start with the oldest stuff first, being, of course, ECT. It's incompletely understood how this works, but it's thought to, of course, it's known to induce a generalized seizure, and this is thought to lead to a broad network reset. It's also thought to increase BDNF, and hence neuroplasticity, and normalize an aberrant default mode network along with their associated limbic circuits. And it's also thought to reduce subgenual anterior cingulate cortex activity, and this is indicated for severe or psychotic depression, also catatonia. Um, r- uh, RTMS, which is repetitive transcranial magnetic stimulation, this targets the left dorsolateral prefrontal cortex. It's increasingly used in the outpatient setting. Especially with some new data from Stanford. showing that this can actually be used to very rapidly target depression. The way that it's thought to work is by increasing the connectivity of this dorsolateral prefrontal cortex that's being stimulated with the dorsal anterior cingulate cortex, and indirectly reduce the subgenual anterior cingulate cortex from being overactive. While DBS actually, targets that subgenual anterior cingulate cortex directly, it's and also has some downstream effects in the more midbrain dopaminergic areas like the ventral capsule and the ventral striatum, and the medial forebrain bundle as well. And of course, it's rarely used. You have to be a very, severe case of depression, but it has pretty promising data to back up its use. Some other, neuromodulation that we use or is the VNS, or vagus nerve stimulator. This targets and modulates limbic circuits by increasing the release of norepinephrine from the locus coeruleus and enhances neuroplasticity. This typically works slightly slower than these other modalities that we talked about, but tends to have really durable, long-lasting change. And then something else that I didn't mention here, but some people consider ketamine and psychedelics as interventional psychiatry modalities. I think this just looks very differently than all these other things that we talked about, but it definitely produces network level changes. So I didn't add it here because it seems so different, but it's definitely interventional. It's just not really, surgical. And these modalities are combined with therapy. It's interesting to think of combining neuromodulation with psychotherapy, similarly to how psychedelics are paired with psychotherapy. And ketamine, of course, is also a general anesthetic for ECT. And so some people have thought of combining ketamine with ECT, since you have to go under general anesthesia for it anyway. But there's been some conflicting data on that, but it's not unfavorable. And so in terms of the relationship between depression and different neurological conditions, I'll talk more about these conditions in their own specific talks when we get to our neurology um, block. And the overall theme for now is that this pathology basically involves a lot of the same common circuits that we've talked about before. So in Parkinson's disease, the prevalence of depression is up to 50%. And this is thought to be due to the generation of dopaminergic, serotonergic, and noradrenergic pathways. So it's not just a dopamine issue when it comes to Parkinson's. And but because there is definitely a dopamine issue going on, I like to just kind of clinically start patients in Parkinson's who have depression on Wellbutrin for its dopaminergic benefit. But there's no reason to not start SSRIs or SNRIs, because data shows that they're just as much, they're just as equally helpful, especially for fatigue as well. Um, and then speaking of fatigue, in MS, there's a very high prevalence of depression and increased risk of suicide in patients with MS. We're not really sure why. Maybe it's thought to be due to the inflammation. Fatigue and cognitive slowing are some of the most common symptoms here, and SSRIs are first line for these patients. And another thing that's common with multiple sclerosis that we'll talk about in a different lecture is that pseudobulbar palsy is something that commonly happens. And if they have a pseudobulbar affect, then the treatment there would be Nuedexta, which is a combination of dextromethorphan, which is an NMDA antagonist, and quinidine. And another point is that the therapy itself for MS can cause depression. So interferon therapy, even though it's not as common anymore, can cause depression. So it's good to screen mood before considering anything like that. Um, and then mood disorders and epilepsy are super common. Anxiety may be even more common. And both are somewhat difficult to diagnose because the medications can have side effects that can worsen energy levels and motivation, and conflate with the two. And so that's why we use that different screening tool. Instead of the PHQ-9, we use the NDDIE for to screen for depression and epilepsy. And certain SSRIs would be actually SSRIs in general would be first line here. They don't really affect the seizure threshold, with the exception of, not an SSRI, but Wellbutrin would be an exception here because Wellbutrin definitely lowers the seizure threshold, especially for people with a low BMI. Lamictal, if we're going to start somebody on an anti-seizure medication anyway, if they have depression or bipolar depression, if it's indicated, Lamictal has good mood stabilizing and antidepressant effects. So that could be something to consider. And then stroke-related neuropsychiatric issues are super vast. The picture here on the right is from the Future Stroke lecture, but you have all kinds of issues, neuropsychiatric sequelae for different kinds of strokes. And so we're going to talk about this in way more detail. There's been a lot of different trials of SSRIs for stroke, especially post-stroke depression with conflicting results. But I would treat it just like any other neurologic condition, or with depression, you just treat the depression itself. And then there's way more than we could talk about here. Uh, so we'll go on, and we'll close off with this neuropsychiatric way of seeing mood disorders, and trying to integrate all the things that we've talked about so far. So in terms of our formulation or the way that we think about patients, we would integrate, first the phenomenology of the presentation, like what we're seeing in front of us. So that would include the jargon from the DSM-5 criteria just to justify the diagnosis and its severity. We can include the neural circuits that are involved, including maybe even like possible lesions if this is a neurological patient, and more commonly the brain networks that we don't see with our naked eye. Um, Cognitive symptoms are extremely important to think about and name, especially certain domains that are affected, like working memory and attention and things like that. Any medical contributions to the presentations, as usual, along with any substances or medications that might be contributing. Their own psychosocial context is always going to be important to include, along with the, cultural meanings of their mood symptoms. Um, and then a risk assessment is always done in terms of their risk for suicide or homicide. So ask if there's any risk, any thoughts that they have of ending their lives. Usually, I explicitly ask if they have any thoughts of killing themselves, if they have any plan on how to do so, any previous attempts, and any behavioral, like preparatory behaviors related to this. It's always important to screen for, and can be life-saving. And ultimately, a personalized treatment plan will integrate, all these factors and integrate multiple modalities. So not just medication, but also psychotherapy, or maybe even neuromodulation if it's indicated, and always lifestyle interventions, and advocating for behavior activation as well. And so these are my references. And thanks so much. And again, with every lecture, there's always some questions at the end as well. Thank you.